at this point in time, I would also love to introduce our very first speaker. Now, she is a licensed OBGYN, and she's absolutely thrilled to be joining us here today. Dr. Oldham graduated with a bachelor degree in history from Stanford University. However, she had no doubt that medicine was in her future. From Washington University Medical School, she went on to Rush University Medical College in Chicago to complete her residency in OBGYN. Dr. Oldham remained on faculty at Rush with practice focus to include the interdisciplinary management of bleeding disorders in women and girls, and to selling her solo private practice to Northwestern Medical Group 6 years ago. Now, still on faculty at Northwestern, but with a desire to make an impact on health disparities in the public health sector, participation in the community medicine has been Dr. Oldham's major objective for the last 3 years. She is the newly appointed gynecologist for Amita St. Francis Hospital in Evanston, Illinois, charged with the responsibility of promoting women's health care in both neighboring private and underserved communities. And we are so delighted that Dr. Oldham will be joining our session today. So please, ladies and gentlemen, join me in welcoming Dr. Lisa Oldham.
Thank you so much, Lena. I think what we'll do is start with our case study, and hopefully this case will resonate with our audience to sort of highlight the issues that we have when taking care of patients who have bleeding disorders, and actually even just any of our patients, gynecologic patients who have difficulty managing their bleeding profile during their menstrual cycle. So we're going to talk about Izzy. Izzy is an 18-year-old college-bound rising freshman and Division I field hockey player who presented to my office a whole 5 days prior to departure for college orientation, requesting a Nexplanon insertion for contraception. Izzy was taking a combination contraceptive pill, but was having difficulty remembering to take it daily, which was a problem because she was sexually active. But also, per Izzy, quote unquote, my periods are worse with the pill anyway. So she wanted to switch. Menarche, or age of first period, was at age 13 or 14 per Izzy. She couldn't quite remember. And when asked, are your periods heavy? She said, yeah, I mean, not really. I think normal though, which is pretty common for us as gynecologists when we're asking questions about a patient's menstrual cycle. My recommendation to dig a little deeper clinically was pleasantly declined. I could tell that she was uncomfortable, and I could sense the pushback, so I didn't want to push her. A Nexplanon was inserted without complication, and her follow-up was scheduled for her winter break. But before that time, and just 2 weeks after I met Izzy, her mom called the office with concerns. Izzy could not complete team practices because she was short of breath whenever she was running. It required that she now see a local school physician for full evaluation. She was found to have severe iron deficiency and a hemoglobin of 9. Her mom was completely unaware that Izzy's periods were ever a problem. So we obviously need to dig a little deeper in patients who present like this. Next slide. So I thought what we do is kind of start with a menstrual cycle to begin with. It's confusing. I don't know if you've ever seen a graph like this, but these are graphs that we often might see in a health book in high school and college, even in residency in medical school. We'll see these menstrual cycle graphs that are perplexing even to doctors. Next slide. So we'll break down the menstrual cycle. I'm going to break it down into 3 parts. We're going to have the pre-ovulatory phase, the ovulation phase, and the post-ovulatory phase. So what you're looking at right here is a cross-section of the uterus. And actually, this is a part in the early first half of the menstrual cycle, or first 1/3 of the menstrual cycle, that we call the follicular phase, where your brain is now finished with its menstrual cycle and is selecting a new egg, telling the ovary, go, we want a new egg to start a new cycle. Next slide, please. This is the late second 1/3 of your cycle. I say half, but it's really the 1/3. And you can see that the glands are starting to get a little bit more organized, and they're busier. And this is an estrogen dominant part of your cycle, where the egg is actually creating an environment that is perfect for ovulation. Next slide, please. This is a pictorial of ovulation to the left, and to the right, an actual picture of ovulation as we see it in women and girls. And so the white area is the ovary. The red is actually what's called a corpus luteum cyst, or a quote unquote ruptured cyst. It's small and it looks pretty benign here. On the very top, you'll see what's called a follicle, and embedded inside there is your little egg. Next slide. And those nice pictures actually don't always feel so nice in most patients who are ovulating. Ovulation is usually drama, especially if you have a bleeding disorder, because that egg is being released and there is some blood loss during the period of time that the ovary is really released. This could actually be somewhat life-threatening for some of our bleeding disorders patients, but for every woman, it usually is a little bit uncomfortable. Next slide. This is a picture of the uterus after you've ovulated. This is a progesterone dominant portion of the cycle, and this is a period where progesterone is stabilizing the endometrial lining, waiting for a fertilized egg. Next slide. If the egg does not fertilize, then progesterone levels plummet actually, and all of those glands start to deorganize, and there's a lot of bleeding, as you know, and everybody. And this is basically like the scaffolding coming down, the end of the show, and we're going to start over again. Next slide. For everyone, I think I can say menstrual cycles are painful and they're uncomfortable. And so I call this the angry uterus, because everybody really has it. And, you know, if you've got a bleeding disorder, it's just that much more dramatic. Next slide, please. So what is normal versus abnormal bleeding? So we talk about menorrhagia in medicine, and the definition of menorrhagia, which really was actually characterized for clinical trials mainly, and that's menstrual blood loss greater than 80 milliliters per cycle. That's hard to sort of figure out. So I usually try to determine if a patient's anemic, because if a patient's anemic just because of her period, I know she's got menorrhagia. And quite frankly, all that matters is your period getting in the way of your activities of daily living? Because if you're not able to do what you want to do just because of your period, if it's upsetting your life in some sort of way, we need to come up with some sort of a treatment plan that will make it more manageable for you. Next slide, please. So patients often ask, you know, what do I say when I go to the doctor's office? I feel uncomfortable, or, you know, it's just a sensitive topic. So you don't know really what to do in order to make sure that your 15 to 20-minute visit is actually productive. And so I came up with this tool for mainly my adolescent patients. Your pocketbook, your back pocket, and your pearls. You need to take those 3 things with you every single time you meet up with a new gynecologist to talk about your period. So your pocketbook is really just you, your past and present history, your family history. For us as clinicians, it's really essential that we know what your history has been and what your family history tells to your story. And that back pocket part of it is actually you as an expert of your own condition. You're going to, if you haven't already, you probably at some point in your life will interface with a physician or a provider who doesn't know nearly as much about your bleeding disorder that you know yourself. And so we do rely on you sometimes to challenge us, to know more, and to help you and to understand a little more about what you've been through. So your journey is your back pocket. Your expertise in knowing about your own condition is right there, and it's helpful to us. We do rely on you as the patient in this collaboration. We need that. And lastly, the pearls. So You know, if you've got any patient who's got bleeding issues deserves an ultrasound or some form of imaging to determine what's going on. Sometimes there's other things in play. We want you to ask for and advocate for labs that are outside of your typical von Willebrand or bleeding disorder labs that you follow regularly with your hematologist. Some patients might have thyroid disorder and bleeding complications related to that or other medical conditions. And let's remember that there are some non-bleeding disorder related gynecologic issues. We want you to use assessment tools like a menstrual calendar, the Better You Know section in the National Hemophilia Foundation website is got many tools that are available. And we actually, as providers, really love, more objective measures of what your experience is as a patient, what you're going through. And your apps, I know, are very popular, but they're not really accurate. So all of these assessment tools or any of them that you can bring at your visit are very, very useful to us. So let's look a little bit at some pictures of some non-bleeding disorder related gynecologic issues that can cause bleeding. Next slide.
They're low graphic, everyone, just a heads up.
So this is actually a picture of an ovarian cyst. It's benign, it's not a cancer. This is a patient who was actually early in pregnancy and bleeding. And so her cyst had to be removed. A lot of cysts are not this big, but small cysts even cause abnormal uterine bleeding and often don't have to be removed. So I don't want to frighten anyone into believing that every ovarian cyst has to be removed, because they don't. But we do need to treat them because they do cause bleeding a lot of the times. Next slide. All right, so this is the inside of the uterus. This is the uterine cavity, and it is a fibroid. It's called a submucosal fibroid, which means that it's underneath the wall of the uterus, and these are notorious for causing bleeding even when they're very, very small. Because it's small, it can be removed minimally invasively, and that's the silver instrument you see. It's hysteroscopically being removed, and this is a perfect example of when we as surgeons need to collaborate with our colleagues, because it requires an anesthesiologist in play here, a hematologist, to make sure that when we're removing these even small lesions that we don't have hemorrhage that's uncontrolled intraoperatively. Next slide, please. Okay, to the left is a very common condition called a benign ovarian polyp. Again, it's on the inside of the uterus. You can see the blood vessels are pretty engorged. And so these are patients who can have, everyday spotting that's annoying and difficult to manage, not necessarily life-threatening bleeding. Or this is a patient potentially who's not getting pregnant because this polyp is in the way. And this generally needs to be removed. If a patient's not having bleeding and isn't trying to get pregnant, they're benign. They can be left alone. To the right is a picture of something called adenomyosis. It's very similar to endometriosis, where the glands of the inside of the uterus are in the wrong place. In this case, adenomyosis is those glands are not just on the inside of the uterus anymore, they're in the wall of the uterus. So it makes the uterus a little boggy, like a little, the contractility of the uterus isn't as strong as it normally would be. Nothing wrong, no issues with fertility, but bleeding complications and pain. So that's just a little bit of a summary of the things that we treat as gynecologists, so that you understand that there are gynecologic issues that you can also have with von Willebrand or other bleeding disorders that, when they come together, are really difficult to manage at times. Next slide. So remember, your pocketbook, your back pocket, and your pearls at every office visit, and you should be well ahead of where you would be if you just kind of went in there not knowing what to say or do, because it's sensitive and it's uncomfortable topic to talk about.
Thank you so much, Dr. Oldham, for this super, super informative, short little overview. And then just as a friendly reminder to everyone, and in relationship to what Dr. Oldham said earlier, there's some wonderful tools on our Better You Know website as well. So I believe it was posted in the chat as well. Make sure you check that out. There's some great resources for you. Also, just as a friendly reminder, so I misspoke a little bit earlier, this is being recorded and it will be available on demand within 24 hours. So just as a slight little reminder and correction there as well. So in the interest of time, I would like to transition to the panel discussion where we will actually hear from two lovely individuals who are affected with VWD along with Dr. Oldham. And now the panel will actually be discussing why people who have periods should be talking about them a lot more and how being open about periods can lead to better health outcomes. And we'll also discuss some ways of how you can start these conversations with your family members as well as your healthcare providers. And with this, I would love to introduce our first panelist. We could go to the next slide. Please, Bree Policki is our first speaker, and I'm sure she can share her own story and who she is a lot better than I can. So I'm going to hand this over to Bree here.
Thank you, Lena. Hi, everyone. My name is Brianna Policki. I go by Bree for short. I am 29 years old, going on the big 3-0 this December, and I am currently living in northern New York State, up near the Canadian border, near the Thousand Islands region. I live with my husband, who I recently married last June during the COVID pandemic, and we moved from Connecticut all the way up to New York with our big puppy, Mattis. He's a big pit mastiff, and as you can see from the photo, he looks very intimidating and mean, but he is the biggest fur baby you'll ever meet. We love him dearly. We have no kids. I am an aunt to my niece Sophia and my nephews on my husband's side who live in Myrtle Beach. And we love all things outdoors, hunting, fishing, hiking, all that stuff. We are into it. I try to maintain an active lifestyle. I love fitness and nutrition. I'm an RN. I've been a nurse for about 7 years now, with a lot of experience, not in the bleeding disorder community, ranging from pediatrics, women's health, med-surg, orthopedics. I was in dialysis for a short time, and most recently worked in the home care community doing case management and admissions. I was diagnosed at 3 years old with VWD. I was typed at 3 as a type 1. However, it wasn't until I turned 12 and experienced my first period that I went through a really long journey and was retyped or re-diagnosed, I guess you could say, into the type 2M category, or as they like to call me, a type 2 question mark. I ended up with severe menorrhagia, and I'll hopefully talk to you more about that as the panel goes on. But it was definitely quite a journey, and I'm happy to be here to share it, and hopes to help anybody out there who's experienced anything similar.
Thank you so much for sharing this information, and welcome to our panel. So at this time, I would love to introduce our second panelist. So if we could please move to the next slide. Our next panelist is Kimmy Walsh. And again, I will hand this over to her because she can tell you a lot more about herself, much better than I can.
Don't forget to unmute.
Kimmy, you're muted.
Hi, everyone. I'm so glad to meet everyone. I'm Kimberly Walsh. My friends call me Kimmy, so please do. I am diagnosed with von Willebrand type 1. I was diagnosed when I was about 35 years old. I have 5 children. 4 of those 5 are diagnosed on paper with von Willebrand type 1, and the other one that is not diagnosed on paper actually has the symptoms. I'm a grandmother of 2, as you can see in there, my little precious, my pride and joys. I thought I loved my kids. I am also a registered nurse. I worked intensive care for 20 plus years. I also did some case management, some hospice, and I'm a director of a memory care unit here in Pittsburgh, Pennsylvania. I also volunteer as the camp nurse for Camp Hot to Clot here in Pittsburgh, obviously until COVID hit. And I also teach dance class to young children. My von Willebrand was handed to me from my father, who you can see in the pictures there. He's no longer with us, but he's always in my heart. He was not diagnosed probably until about 10 years before he passed away. before he had a cardiac catheterization. And you can see from the picture, my son obviously had a nice little hematoma on his head when he was born. I was not diagnosed at that time and had no idea. They just told me they bumped his head when he was born. I'm so pleased to be here tonight. I've had so much experience knowing I had von Willebrand and not knowing I have von Willebrand disease. And I look forward to sharing it with you and hopefully getting to know a lot of people and making some new friendships, lifetime friendships like we've all made here. Thank you for having me.
Thank you so much for sharing. That's very meaningful to our community. And then, while we have talked a lot about her occupational background, Dr. Oldham is joining our panel as well, and she wanted to share a little bit more about her personal life as well. So if we could go to the next slide, I will hand it back over to Dr. Lisa Oldham.
Thank you, Lena. Not easy to talk about myself, but I'm going to try for Nicole because she asked me to do that. I'm a native St. Louisan, very proud of that, but I wasn't at one time. I thought I escaped and I was going to go to the Bay Area and never return. Wrong. I met and married, fell in love with a guy and I married him and he brought me back to Chicago. And I've been here in the Chicagoland area for the last 24 and a half years. Practicing, which has been wonderful. We have 4 kids, 3 boys and a girl. Much easier to talk about them than it is to talk about myself. All 4 of them Cardinals fans. So my husband lost that. Has not harmed our marriage, but I win with that one. So as a family, we ski. We love to travel to beautiful places that have beautiful sunsets. And outside of sports, travel, and leisure, one of the really big things I've tried to stress with my kids is service to others, because to whom much is given, much is expected. So far, so good. So be it fighting hunger, hurricane relief, clean water scarcity, issues pertaining to the rights of women and girls, children. Now COVID-19 vaccine hesitancy efforts, we aim to try to make a meaningful difference if and when we can. We got a dog named Ziggy, who is 7 years old now and is still not much bigger than that picture. And I'm lucky enough to have found a career that allows me to have an intersection between being fully present in the living and being on this planet at this really very, very unusual and complicated time in our lives. Been very, very, very blessed to be involved in this area of medicine that shockingly a lot more of us as OBGYNs are not. And I'm very grateful to the National Hemophilia Foundation for inviting me today to be able to participate in this panel.
Well, I think I can speak for all of us. We are very glad that you have actually accepted our invitation and you're joining us here today. So we are just glad you are here. And I think you did a wonderful job talking about yourself, even though you didn't feel comfortable to do so. So I think that was fantastic. So at this point in time, I want to ask you a couple of questions and just really want to find out a little bit more. So to start out with, I'm going to pose this to you, Bree. So in your family, how did you talk about periods and how were periods explained to you?
So at a very young age, as early as I can remember, my family never really discussed the topic. I learned most of my information, I'd like to say, through my middle school health education teachers. And I have an older sister who's 2.5 years older than myself. And once she got her period, it kind of sparked the curiosity in me. So I began to ask more questions. But I don't remember a time when my parents sat me down, or my mom never really had the talk. If she did, I honestly don't remember. But I don't know if maybe there was some sort of hesitancy from their end, just because I did have a bleeding disorder, and nobody in my family has a bleeding disorder, so no one ever had any experience with it. Maybe it was a fear. They weren't sure how to approach it because they weren't sure what was going to happen. But I definitely feel like I got most of my information from my sister. Once that happened, I started opening up more to my mom, and we talked, and then my health professors.
Thank you so much for sharing. Kimmy, I want to pose this question to you too. How was this handled in your family? And did your experience with a bleeding disorder change a little bit how you were talking to your own children about having a period?
So for me, I got almost all of my information in school, probably about 6th or 7th grade. When I had issues at home, it was pretty much just, it was told to me, that's just the way it is, that's life. You just need to kind of get used to it, even though nobody else really had the symptoms that I had. In school, really didn't have any support, got in a lot of trouble for, quotes, skipping gym class because you don't want to swim in the pool. The nurse in the school really just kind of would change my clothes, send me back to class. Failed a lot of things, really didn't participate in a lot of things, missed out on a lot because of no real support, no one really knew. But then as I got older and I became a nurse, and I really didn't learn a whole lot even then. We learned a little bit about hemophilia in nursing school, probably about 10 minutes. And then until I got diagnosed with the issue, no one really ever brought it up to me, even, coworkers and physicians that I'm friends with in the community. And that's when I finally got diagnosed. And even then it was kind of a little bit rocky. Don't worry about it unless you're in a car accident or having surgery. Let's hope you're awake for that. And, that's when I finally got on to a treatment plan. And that's where, I learned about the nose treatments, and then eventually the factor treatment. When I was 38 years old, I finally was able to try that.
Thank you. So did any of that change as you were communicating with your kids? Did you make any changes when you were talking about periods?
I sure did. I didn't do a lot of probably talking to them, but they grew up, I was already involved in this community. So they got to really learn, kind of like Bree as well. They learned from the best of the best. They got to hear all the great physicians that are involved in our community. They got to go to the annual meetings and meet other people just like them. Some people that had some really tough stories, some people that had stories like Nicole's and like her sisters. And, they didn't have to go through what I went through and what some other people went through. So they're very blessed that they got the best education that I could, much better than I could have ever given them without the community.
Yeah, this community is just wonderful in supporting each other,
amazing.
educating each other, advocating for each other. I feel very blessed, honestly, to have met all of you. So next question, Bree, I'm going to post this back to you. So can you tell me about a time where, or all of us essentially, where you have experienced heavy menstrual bleeding? How did you navigate that situation? And did you have any support? And if you didn't have any support, where did you find support?
Of course, I had a lot of support, and my story that I'm going to tell goes hand in hand with the story of how I was actually diagnosed as well. So I'll try to keep this as short as possible, but it all kind of started for me. So I was diagnosed at 3 as a type 1. And for me, bleeding as a kid growing up was nosebleeds. I would get nosebleeds all the time. Every night I was waking up in the middle of the night with a nosebleed. And so because I was type 1, I was taking Stymate and Amicar to help treat my bleeds. And little did I know that they weren't really doing what they should have been. They weren't working for me, and my nosebleeds would still last for hours. I had to get my nose cauterized a couple times in the ER and that sort of thing. So fast forward to when I turned 12 and I got my first period, I ended up in Albany PICU with 14 blood transfusions, 4 platelet transfusions, and 4 plasma transfusions. And I was, at the time, I believe, just started on the Humate-P infusions, and those seemed to be working. However, I was doing them every 12 hours, and apparently it was found out later on that my half-life drops off after every 8 hours, and I should have been taking it more frequently. So again, my bleeds just weren't being controlled. So when I had my first cycle, it started out normal. I bled for about 7 days and it started to taper off. I spotted for a day, and then I went swimming in my grandparents' pool. And when I got out, the floodgates just opened back up again. And from that point on, it was severe menorrhagia for about the next 3 or 4 days until I ended up in the hospital. But during that time, I didn't really know what was normal. As I said, I didn't know a lot of people around me. that talked about it. So I was in 6th grade. I remember there was only one other girl in the class who had her period. So I was asking her questions, and I was running to the bathroom every 5 minutes, and she said, "Nope, that's not normal, Bree. Like, you should probably tell somebody about this." And so then from that point, I started having the talks more so with my mom. My blood levels were being checked by a local blood center almost daily, and they were keeping me posted on my H&H and that sort of thing. The one night I pitched a championship softball game, and it was the first night I ever learned how to use a tampon. I'll never forget it, because I couldn't play softball with a pad bleeding everywhere. And TMI, but that's just how it was for me. And I was running back and forth from the pitcher's mound to the bathroom in between innings the entire game. I ended up pitching a shutout, and to this day I'm still proud, and I don't know how that happened. But that very night I went home and I nearly passed out on my bedroom floor from just so much blood loss. And it was at that point they rushed me to Albany, and they discovered she's not a type 1. Don't know what we were thinking. So they sent my blood to Wisconsin, did a bunch of studies, and it turned out I have a rare gene mutation that apparently has never been documented before. There's no other cases known of the specific mutation that I have. So they put me in the category of a type 2M, but I'm really more of a type 2 question mark, being that it is so unique and unheard of. And so they have told me that I exhibit traits of both a type 1 and a type 2 VWD patient. So it's been tricky, it's been frustrating, and in order to control my bleeding, they had to pump me with a 1.5 packs of birth control pills in a day to thicken my uterine lining. I was on the pills, the shot, all kinds of things to help control my bleeding, because I was having breakthrough no matter what. And then when I was a senior in high school, I got so fed up and frustrated with the meds that I ended up switching over to a Mirena IUD, which I have had ever since, and it has pretty much slowed off and shut off my system so that I don't cycle anymore. And it's given me back my quality of life. However, as a woman, you kind of feel like, you know, maybe I should be cycling. I don't know if this is healthy and that sort of thing, but I have to say it's much better and easier living with that than it was with all the other medications I was on. But I had a huge support system. My parents, my sister, my friends, my doctors became the biggest network and circle of networking physicians I'd ever seen. So that I was really blessed to have everybody kind of on my side working together.
Thank you. Thank you so much for sharing that information with all of us here. Definitely a tumultuous time in your life. So Kimmy, I want to pose this question to you as well. So can you share with us a time in your life where you experienced heavy menstrual bleeding, and how did you navigate it? And did you have any support? And if not, how did you find support?
So I, from the very beginning, that my periods were awful. My shortest was 2 weeks and my longest was 52 days. And then after every child, they tell you can bleed up to 6 months after you have a child. And of course I did. So it seemed absolutely normal to me. So I didn't have, a lot of support at home. I was married. As I would have to say that during my childbearing years, that's when, when I was having the kids, that's really when the symptoms really started interfering a lot more in my life as far as work and having to call off or call out. And although I worked around all kinds of doctors, hematologists, took care of people that were bleeding, I never really got any advice or any support of that. I checked with my PCP at one point and they said that it was probably allergies. So I was started on a whole bunch of antihistamine treatment for allergy problems, because they said that's why I was bruising. Well, then that just made it even worse. I bruised everywhere then. That was actually awful. It wasn't until a good friend / cardiologist noticed that I had some bruising. And he at first thought that I was in a bad relationship, because I had handprints here on my arm, and that was just from myself scratching. So that was interesting. And at that point, that's when I finally got to a hematologist, and I was anyone that specialized in bleeding disorders. But in general, she was able to give me the diagnosis of von Willebrand's. I got the DDAVP challenge, and that's kind of sent off to school with that. And then later on in passing, I ran into a friend, and that's how I got involved in this community. So now I get to go to a hemophilia treatment center, which absolutely turned my life around. And that's where the support has all come from, as well as my family now, because they're all educated now. So once they finally got an idea of what was going on, I wasn't whining, I wasn't avoiding school, I wasn't avoiding work. Once people got educated, and the ignorance was gone, they understand and they get it.
Thanks so much for sharing. Education truly is empowering, isn't it? So, Dr. Oldham, I want to pose the next question actually to you and start out with you. So, often there is a lot of stigma around these conversations around our period in particular. So, how can we actually get around or over these stigmas?
Talking. I mean, I am sure that these stories that we're hearing right now, were not drawn out in real time, and that there's a lot of sort of looking back and remembering, but in the moment having not an opportunity to really express what was going on unless there was something really obviously happening, like you're coming out of a swimming pool and hemorrhaging right there in front of your grandparents. I mean, women suffer and girls suffer in silence. And it oftentimes starts at the very first period or menarche. And I think talking about these things and making this normal, like just norming a discussion. I've gone into gynecology, so this is normal for me. And I'm pretty sure that I did, because my mom did not have heavy periods and I did. And I needed more information, and then it made it normal for me. But when you're not a physician, and you're just trying to have a normal childhood and then adolescence and adulthood, there's a lot of shaming that goes on with the feeling of being different and just being a girl. I mean, now with a lot of the different things that are happening in society to support women, it's getting a little bit better. I remember going to the pediatrician and never having anyone ask me about my periods. Zero. Did you start? Did you not start? That was it. Not, are you having pain? Nothing else. I think my daughter would be okay with this. She's 14, and I took her to the pediatrician, and pediatrician asked a few questions. Can't really complain, but I'm also a gynecologist sitting next to my daughter. So I think it's just, first of all, normalizing the conversation. We are girls. And as soon as we start having our period, a whole lot has already happened. You've already gone through puberty. 2 weeks before you started your period, you ovulated. You didn't even know. And probably were moody, having a bad day, and some bowel digestive issues probably happening. And the conversations really have to start before menarche. It really needs to start before the periods begin. The American College of OBGYN recommends, I believe the age is somewhere between 9 and 11 to see a gynecologist before the drama starts, to first establish a relationship so that you feel comfortable with your girl doctor, or whatever you want to call her, or him. And also to just start to get comfortable having the conversation, discussing what's going to be happening inside your body, or what's happening inside your body, and how normal it is, and the things to come to the gynecologist or your pediatrician or family physician about when there's a problem. Because I heard in both stories, both Kimmy and Bree, stories of I didn't really know that, okay, so you just had a baby and you were told it was normal to bleed after 6 months. No, not to the degree that you were, Kimmy. So we have these blanketed statements that we give in a discharge summary, or a nurse may provide to a patient in a discharge summary. Here's your instructions, but everybody's different. And we need to be able to have more conversations baseline as a foundation, so that when things are uncomfortable, there's not a feeling of shame, there's not embarrassment, none of that stuff exists anymore. And you're just telling your story. This is objectively what's going on. This is subjectively what's going on. I like this, I don't like this, this is frightening to me, so on and so forth, so that we can get to the bottom of it. We need to normalize these conversations early on.
Absolutely. I think that is such an important point there to make. So Bree, I want to pose this back to you here as one of our final questions of this panel discussion before we open it up for everyone else. If you could go back in time, what would you tell your younger self? And how would you encourage somebody within our community to find their own voice?
Well, I would probably go back and I would say to myself at a very young age, listen to your superiors, listen to your parents, listen to your doctors, do your prophylaxis like you should. I always kind of had this attitude about my bleeding disorder that I wanted to be normal. I wanted to be like everyone else and do all the things everyone else did. I didn't want to infuse. I kept saying, you know, why me? Why do I have to deal with this and do this? And I would kind of rebel and just not really do the things I was supposed to. And I would sometimes end up with a big bruise after softball practice or something. So I would definitely tell myself to just kind of suck it up, do the things you're supposed to do because they're there to help you and they know better. And I would also tell myself to, you know, I went through a lot of emotional struggle after my experience through my high school years, and it forced me to grow up very quickly. And so I matured at a very young age, and that kind of caused me to pull away from a lot of friends that I was really close with. So there were times I was even bullied and that sort of thing. So I would just tell myself, you know, you're going to be a much bigger, better, and stronger person because of what you're going through now. So try to always find the positive in the negative. It's ended up for me being a blessing in disguise. And I would tell anybody new going through a diagnosis to just be an advocate for yourself. Nobody knows your body better than you do. So no matter who it is, your friends, your family, your physicians, if you know what you need and you know what you're going through, be that advocate for yourself and educate yourself as much as you possibly can.
Absolutely. So Kimmy, I'm going to pose this very last question to you as well. If you could go back in time, what would you say to your younger self, and how would you support somebody in our community to find their own voice?
I would absolutely go back to my 20s and hope that I could be as mouthy as I am in my 50s and just arm myself with as much knowledge as I have now. You know, obviously we didn't have the opportunity to look things up on the internet, kind of like, you know, for Bree, we had encyclopedias from 1960, so I really wasn't going to probably find a whole lot. However, you know, I would be a little pushier and say, this really doesn't feel right. You know, Mom, I really don't think that this is right. I'm so dizzy, I'm so tired, you know. And but I am going to take the bad, all the bad that has happened to me, and I have taken it and put it into something that is really good in advocating for myself, my children, and other people that I've met in the community. And now hitting in my menopausal years, you know, things are really going crazy right now, you know, and that's something that I will be reaching out to my doctors and gynecologists like Dr. Oldham here, because you know, things are crazy enough with a bleeding disorder, and now I'm adding menopause in there, and I don't know if I'm coming or going. It's just, it's a hot mess, you know. So
No
I would
pun
definitely, yeah, exactly. Yeah. When you put your slide up, I went, that's me. So yes, I would, you know, knowledge, and just talk until ad nauseum. You know, when you're out in public and you mention something, someone will get tired of listening to you, but they might actually learn something.
Yeah, that is fantastic advice. Thank you so much for sharing, Kimmy. So I want to open it up to everyone there to answer a few questions before we have to close this session. So the first question that is actually coming in from the audience, I'm going to pose to you, Dr. Oldham. And this particular person is asking about fibroids. So she, as a woman, had fibroids. Is it likely for her daughter to have them as well?
They are genetic. Now, we think, we usually in our community quote a rate of about 30 to 50% of women worldwide with fibroids. It's probably like 70 to 80%. It depends on where fibroids are placed in the uterus, like where they live. as to whether or not they're actually going to cause a bleeding complication. So some women will never know that they had fibroids, because if the fibroid was not in the wrong location, they may not have any. They could even be very big and not have bleeding issues. So yes, they are genetic. It's very possible. Again, my strong recommendation is that if your daughter is starting to have heavy periods, get an ultrasound early on. You can be done transabdominally in a young girl who's not sexually active, and get a sense of whether or not there's anything there. I think that's perfectly fine to do if she's having heavy periods. And there's no radiation with ultrasound. So unfortunately, yes, they are genetic. They're very common, and we can manage these issues pretty easily if we know ahead. And the whole idea is prevention. The more you know, so on and so forth. Hope that answers the question.
Great, thanks so much for sharing. So the next one is actually towards you again as well. Is there has been more discussion about nomenclature and how using the correct terms when a woman or a girl experiences abnormal bleeding. Can you speak a little bit towards that? And then how do you recommend that people advocate for themselves?
I think you mean menorrhagia versus there's about 4 different categories for abnormal uterine bleeding or dysfunctional uterine bleeding. I think that's what you mean.
Yes, I think so too. That's what I recommend.
Yeah, so I don't know that practically speaking, a patient needs to worry so much about that. Menorrhagia, menometrorrhagia, that sort of thing. I mean, there's ICD-10 codes, like billing codes, World Health Organization codes that go along with some of these things. But again, I'm not really sure that it's practical, useful. Dysfunctional uterine bleeding actually though, that means you're not ovulating typically. So I don't think it matters if you're having heavy bleeding, like when we discussed normal versus abnormal. And again, it can be subjective. It used to be very specific, you know, menorrhagia, does she have anemia? Is she having a certain amount of blood loss per cycle? I don't think that that actually is practical at all. I think it really matters to us in our community, and obviously for you, if your life is adversely affected by the amount of bleeding that you're having during your cycle or in between cycles, it doesn't matter. You deserve management to the degree that you desire management to the degree. If you want to take away your periods, like Bree, with some sort of IUD with progestin in it, or not cycling with some other form of combination contraceptive or Depo-Provera, fine. It is healthy and it's safe. You don't have to have a period. Unless you're trying to have a baby, you do not have to have a period if you're taking some sort of hormonal treatment. Did I miss anything? Nomenclature?
No, I think that was perfect.
Okay.
I'm just going to squeeze one more question in here because we're slowly getting to the end of the session, unfortunately. But I want to just pose this very quick. So if somebody has been on an IUD to suppress their menstruation before moving into menopause, how can you actually tell when menopause is starting when you have suppressed menstruation?
Well, it's a very good question. It would be with blood work. So patients will ask me often, you know, am I in menopause? And they're like 49 years old or so. I mean, this is my opinion. Yes. I mean, anybody who's, you know, nearing her 50s is perimenopausal. Our ovaries are not as functional as they used to be early in our reproductive years when we're nearing the average age of menopause, which is in the North America, 51. So all throughout the 40s, your ovarian reserve is dropping. And so, you know, you can still get pregnant. You need to have birth control if you don't want to get pregnant. Do you need to know exactly when you hit menopause? Not necessarily. You can kind of perceive your entry into menopause as being around those ages and start to focus your health care, especially if your bleeding is now managed, on all these other things that are problematic in menopause. That's heart health, bone health, get your thyroid checked, diet and exercise changes. All those things are so important, so that if you're getting into your 50s, yes, you know that you are menopausal. And if you want a blood test, an FSH level, a follicle stimulating hormone level, or luteinizing hormone level too, might be helpful too, because you want to know, that's fine. You can get that checked. And your doctor will be able to guide you as to the meaning of those tests, because sometimes they're not very specific, because moment to moment your hormones are changing when you're perimenopausal. So until you're postmenopausal, you won't know for sure that it's over. And that's when you have an ovarian reserve of about 1,500 more follicles. Like, you still have some eggs, about 1,500. You were born with 4 million. Now you're down to 1,500, and then you stop having your period.
Thank you so much for that clarification. That was very helpful. I know there are more questions. Feel free to email them to us. We're happy to forward them to our speakers as well. We will give you the answers. We're unfortunately at the end of this session, so I want to take a moment to thank our wonderful, amazing speakers, Dr. Alden Bree and Kimmy. Thank you so much for sharing your experiences and your insights. So we really loved hearing all of it, and I'm sure the community benefited greatly from this. So for everyone else, thank you for being here and joining us on this adventure, talking about our periods a little bit more. Again, just to